All right, I'm told we have a quorum, so the Health Subcommittee of the Health and Education Committee will come to order, and please call the roll.
Senator Saslaw, Senator Barker,
Here.
Senator Donovan, Senator Suderline,
Yes.
Senator Lewis.
Here. We're good? Okay. Senator Cosgrove.
Yes, Mr. Chairman.
Senate Bill 55.
We're doing fine.
Good. I have a fairly simple bill for you. It is Senate Bill number.
55.
Double nickel.
Yeah.
Double nickel.
There you go. Mr. Chairman, members of the subcommittee, I have an amendment and usually a substitute for the bill.
Oh, I'm sorry, okay. Have we got that? Thank you, ma'am. Changing 30 to 45, is that it, John?
That's part of it, yes, sir. And it changes some of the language between, it is non-reflective between the House and the Senate. We're going to make the House change theirs,
Okay. All right.
but we're going to ask it for later.
Do we have a motion on the substitute?
Move the substitute be adopted.
Senator Suderline seconds. All in favor?
Aye.
Okay, substitute is in front of us.
Thank you, Mr. Chairman. Members of the subcommittee, sadly, many of us have had to deal with death on occasions, a friend, a relative, and for most of us, that comes with the form of attending a funeral and comforting families that have been left behind. Emotions come with a loss that often cloud our memories and thoughts. And in those cases, we are charged with making final arrangements and handling the details of the estate, information given to the professionals who handle the funeral directors. It may be wrong initially, it's the information they got. Or we may be so distraught when providing the important information on a death certificate there is a misunderstanding, and when we're asked to review the information, we may still miss an error that's been filed on the death certificate. I'll give you a primary example, Mr. Chairman. My middle name is Aloysius. Okay?
You're kidding.
No, I'm not kidding. But I would challenge
Can you
most
spell
people,
that,
including
though?
most of my family, that would not be able to spell Aloysius.
Yes.
So, when my room temperature body is, at the funeral director's disposal, and one of my families comes in and gives my full name, which is John Aloysius Cosgrove Jr., chances are they're going to misspell something in there. What this bill actually does is it allows funeral directors who are licensed in the Commonwealth of Virginia to have 45 days to make corrections to death certificates for minor inaccuracies like this. The director can still, the staff register can still, as always, deny those changes if they seem to be egregious or not in proper form. But this would actually allow families to get some relief from the sorrows and actually the guilt they would feel if they gave bad information. The death certificate is held up, probate is held up, the estate is held up, and so on. Currently, a doctor, just by a letter on their letterhead, can change a death certificate without any question. And this bill will just allow funeral directors who are highly regulated and a very compassionate industry to have the ability to make those changes. That's it, Mr. Chairman.
Simple bill. Is there anybody here to speak in favor of Senate Bill 55? Oh, I'm sorry, John. Senator Barker has a question.
No, not a question, but a comment. My mother-in-law died 2 weeks ago, and on her birth certificate, we had 2 copies of her birth certificate, and they did not have her mother's first name spelled the same on the 2 birth certificates.
Really?
Yeah.
Well, that kind of thing happens all the time. It's
These
not
things are not that much out of the ordinary, so you don't have to be an Aloysius to have it misspelled. So.
Yes, sir.
Mr. Chairman, I'm Brian Small. I'm representing the Virginia Film Directors Association. We are on board with this, and we told that our colleagues with the Independent Association and the Virginia Morticians Association are also on board with this. This has been spoken by the senator, is just to allow us, the same thing the doctors have, is to allow to fix things within a certain time frame that doesn't create a court trip. Currently, yes, the court has the authority to make these changes, but that's burdensome on everybody. This also can be costly. So, this tries to improve the efficiency of things. I don't really think the initial review should be a court matter. Of course, if everybody disagrees, the judge figure it out. But initially, this should be handled administratively as is proposed here. So, yes, we do support that. Thank you, sir.
Anybody else in favor?
Yes, sir. Mr. Chairman, Bo Keeney, representing the Association of Independent Funeral Homes of Virginia. I absolutely agree with my counterpart here. This certainly will make a positive change for funeral directors. It will expedite the process. It will help families with the grieving process. It will save time and effort instead of having to go to the clerk or the court system. So we are fully supportive of it, and thank our counterparts for bringing this forth with you.
Anyone else to speak in favor of the bill? John, I'm looking in here, there are limitations on what can be corrected, right?
Yes, sir. It's actually spelled out starting on line 22.
Okay, yeah.
Correct spelling and names of the deceased, parents and spouse, or the informant, the sex, race, age, date of birth, place of birth, citizenship, social security number, education, occupation. Just all the normal things that would be on the birth certificate.
Yeah, okay.
There could be an error if somebody just gave them the wrong information.
Senator Suderline?
I'm trying to, you said it was on line 22?
Of the
Oh, it's
substitute.
of the existing
Substitute.
law.
Yes.
Right, oh yeah, right, it's existing law.
Except for the 40.
But since we're expanding it to funeral directors, I wanted to make sure there was some kind of limitation. Does anybody speak against the bill? Anybody?
Move to report.
Okay, it's been moved by Senator Donovan,
A second.
seconded by Senator Suderline, that the bill in the nature of a substitute be recommended for reporting. All in favor? Call the roll.
I'm sorry.
Senator Saslaw, Senator Barker,
Aye.
Senator Donovan,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Aye.
Thank you, Mr. Chairman. Members of the subcommittee.
Yes, sir. Senator Hanger, batter up.
Thank you, Mr. Chairman, members of the committee. I have Senate Bill 100, and I do have a substitute to present.
All right, let's get the substitute.
Thank you.
Thank you.
Okay, and I would ask you to adopt the substitute, Mr. Chairman.
So moved.
Second.
Moved and seconded that we adopt the substitute for Senate Bill 100. All in favor? Aye. Opposed? Substitute's in front of us.
Okay, thank you, Mr. Chairman. This is somewhat of a technical bill in that it clarifies and codifies that providers licensed by Department of Behavioral Health and Developmental Services may honor a valid do not resuscitate order within their programs. It's the same allowance currently granted to aides and assisted living facilities who are properly trained in CPR, and it allows hospice care without the possibility of a conflict which currently exists with reluctance with a DNR order because of potential repercussions with the licensing staff at the department. The legislation is still permissive and will allow providers to set policy to meet the requirements, philosophy, and capabilities of their individual programs. The several pages here, but the operational language is on page 1, where we have the new section there, and then toward the end under the exceptions, line 147 to 150. And there are some people here who have requested this legislation that do support it, if you want further clarification of what we're doing here.
All right.
Mr. Chair,
Any questions? Yes, sir. Senator Suderline.
I understand what I read, but I don't understand what's going on to bring this about. Could you help me understand, please?
There's some people here that can clarify that for you. There's a little bit of confusion about what's allowed.
All right, come on up.
Dynamic duo on it.
Well, somebody's got to sit in the chair. You can't both sit in the chair, so somebody
You have to sit in the chair? Go ahead, baby. All right.
pick something.
So-
There you go.
Hi.
All right, tell us what this bill's trying to get at.
Yeah, Becky Bowers-Anier, and I represent the Hospice and Palliative Care Association. And this really came out of several instances in which residents of group homes for DD and for the most part have have residents in them, and the individuals have elected to have hospice care for end-of-life care. And because they are licensed by the Department of Behavioral Health and Developmental Services, and Jennifer Fedura can probably address this a little bit more, there was some hesitance on the part of the direct care staff when the person ceased to breathe and had a DNR order because he was part of the hospice, which is what hospice people do. They didn't honor it because they were afraid that they needed to resuscitate every single person who stops breathing. And so there have been instances in which individuals who are dying have stopped breathing and CPR has been performed on them, and they have elected hospice. And so we wanted to clarify the code to let people know that they don't have to do that in these situations. If a person has a DNR order and it's, of course, in order to get the DNR order, it has to be duly signed by a physician. And so moving on, that we'd really like to get some clarification in the code. So that's not going to totally solve the problem because there are still, we have regulations. No, there are no regulations. But there is conventional wisdom that we've got to save everybody. And that's not what we need to do when a person has elected hospice. Okay. So that's the short story on it. I think Jennifer may want to add a little bit more to it because she represents the
I think Senator
DB side.
Donovan has a question first.
I do. I'm just curious, are these people who are following medical orders?
Well, let me just say, I don't know to the question, the medical order for the DNR should be paramount because they have elected hospice.
Right.
So
but
if
I'm
that's
just
the
saying,
question you were asking me.
If there's a medical order for DNR and it's from the
Yes.
physician, and these are licensees that usually follow physician orders
Correct.
to guide the care, I can't understand why we need anything because they're almost in contempt of not following their license for not following the order.
Right. Becky. Yeah, go.
Tag, you're in.
That's all right. We work together.
Senator Donovan, the programs are licensed. The individuals are not. So they are not nurses. They are direct support people, and they are not licensed. And in 54.1, 2987.1, it specifically talks about the people who must or can follow and must follow a DNR order. And I agree with you. If it were a nurse, they'd be in violation for not following the doctor's order. But these are not nurses. They are direct support people because the hospice nurse may not be there at the moment that the event occurs.
They're providers that follow the orders of the physician in the care of the patient.
That's right. We believe that you're right, but that's not been the comfortable interpretation, and this just clarifies it. So.
Mr. Chairman,
Senator Donovan.
just to clarify, should it say, instead of may choose not to, so to speak, that they must comply with the DNR order and not resuscitate as indicate? I mean, do we need to be specific? I mean, would it be helpful to you if we actually said if a DNR is in place for a patient, duly signed and attested that nobody should provide CPR?
My concern with that is that a DNR order for a healthy person that has been duly entered by a physician, his family's wishes, whatever, if they have a sudden cardiac event, I don't think we necessarily want a direct support professional who is not licensed, not trained, to make that judgment on the spot.
I don't.
So what is the alternative? I mean,
They are trained to begin CPR, call 911, and when the EMTs arrive, if there is an order and the EMTs see the order, they then make their judgment. that is much easier in terms of application and interpretation, and not the circumstance that we're really trying to address, which is when someone is on hospice care, end-of-life care, and the order is posted clearly over the bed, and it is clearly end-of-life, that they not be, that their interpretation not be that they need to do CPR in that instance. I think there are two different kinds of instances here. And I know that many of my members would be very nervous about entrusting the kind of implement the DNR order when someone, maybe they haven't, it's a fast judgment. It's quick. You've got to call 911. You've got to do something quickly. And I'd rather have them take the action.
Mr. Chairman, just to
Senator
clarify,
Donovan.
are we talking about are we talking about a DNR in both these instances, or are we talking about a oh gosh, Scott, what's it called that we ask all the hospitals to your will advanced directive? Are we
Advanced directives. It's generally a DNR order that has been, and to be fair, I think we have very few of them. It used to be more common for families to say, don't do anything. It's rare now.
So you're trying to protect the hospice.
The hospice, I've been in this business a long time, and one of the joys of this way we do business now, Doctor, is that someone can come home at the end of their life to a group home and be with people they know, staff they know, their peers. Sometimes the family is there. Mom moves in a chair 24/7. It's the way it should be. And we would like that to be able to continue. I mean, I know that sounds awful, maybe, but it's true. I mean, that's the way it should be, and this is their home, and they should be able to come home.
Mr. Chairman?
Yes, sir.
Just
Senator.
as a follow-up, father-in-law died in my home in hospice, and so I'm familiar with all of this. I think this is really confusing. I don't object at all to you wanting to solve the problem. I don't know who's the responsible party. The department, if you're talking about hospice in a home, there are requirements about DNRs being posted on a door.
That's right.
And it might need to be that if a DNR is executed in hospice care, all employees that are there must be briefed or aware or or educated. But this is department may direct program employees certified in CPR to comply with the program participants' valid written. This is really, it's my opinion that this is very confusing.
It is the same language as was used up above for assisted living facilities, and we just picked up the same language. It was.
I see. Okay.
Let me ask counsel, is there anything weird about written order is issued by the program participants attending physician as opposed to signed by the program participants attending physician?
But it may not even be it may not be the program's physician.
No,
because-
it's the participants.
Participant in the program.
It's the individual's physician.
Okay.
It's the individual's physician.
Is there anything strange about that?
I don't think issued versus written, I don't think there's anything strange about
Issued
it.
versus signed.
I don't think so.
Okay. Any other questions from the subcommittee? Anybody else to speak in favor of Senate Bill 100? Anybody who wants to speak against Senate Bill 100? Okay, Senator Hager, you want to say anything else?
No, obviously, this is not an area of expertise for me, but I think it's a common sense type thing that could be accommodated. I have legislated in this area for hospice care in homes where the religious beliefs dictate different types of treatment, where it's more like a family, you gather around and you don't take extensive measures. But I think this is a common sense thing to clarify. And it seems like Senator Donovan wanted to go even further. Is that what you were?
Well, no, I just, Mr. Chairman, if I may, the language on lines 147 to 150, that is new language, is so much more clear. It may be, but you're also sometimes not dealing with a sophisticated workforce. I just wonder if it might be worth replicating, this is clear.
In
Any employee.
the substitute.
And yeah, over here on lines 14 to 17, if you want to say a program, but I mean, I know exactly what lines 147 to 150 say. I'd really have to spend some time, and I mean, I know you've replicated it, but it probably needs to be amended in the other part of the code.
All right.
But, I mean, that's up for, I mean, I agree with the concept, I don't know if you think it's confusing.
Well, the people I've been dealing with who deal with this on a regular basis think this takes care of the issue that's at hand. So that's where I'm at.
All you can do.
Yeah.
Okay. All right. The substitute is in front of us.
Mr. Chair,
Yes, sir.
make a motion to recommend reporting to the full committee.
Okay. We have a second?
If we can talk about it as we go forward. I don't know that it's that important. I want the endpoint too.
Right.
Sometimes we do stuff here, and it makes it a lot harder for healthcare providers to know what we're doing. And I think the whole point is for us to make this really clear for them.
Well, that's why we listen to what you say.
So I'll abstain, and so
Okay.
that I can look at it and see.
Better second the motion.
Yeah. Okay. All right. So we have a motion and a second on Senate Bill 100 that it recommend the reporting of the substitute. All in favor? Call the roll.
Senator Saslaw, Senator Barker,
Aye.
Senator Donovan,
Abstain.
Senator Suderline,
Yes.
Senator Lewis.
Yes.
3 ayes, one abstention.
Okay. So we recommend reporting of the substitute. And I guess you'll have some conversations with Dr. Donovan on the way. So, thanks, Senator Hanger. Oh, and Senator Hanger, you've got SB 119 that you want to go buy for the day. Yep. So while we're on that, we've got SB 119, SB 192, and Senate Bill 617, all of which have been requested by the patrons to go buy for the day. And I'm going to put them in a block and move that they go by for the day, and Senator
Second.
Barker's going to second, and all in favor say aye. Aye. So those are gone, those are by for the day.
Which ones are they?
It is 119, 192, and 617.
Thank you.
Okay, Senator Suderline, I believe by default you are up. And then we've got Senator Donovan too, so whichever one of you wants to go first.
I'm looking to see if the advocates for my bill are here.
You want to wait?
Okay, hand out. Yep.
Good. Hard to see.
You ready to go?
Yes.
All right, Senator Suderline, 231.
Thank you. Thank you, Mr. Chairman. So Senate Bill 231 came out of a work group that's ongoing and trying to help some of our folks that have pretty significant disabilities that they work through. And one of the focuses on that was on the assistive technology that we had some success with during the early stages of the pandemic, and what we're trying to do is find ways to, if it's going to be something that's going to help these people going forward all the time, try to make that available to them. And one of the recommendations that came out of it is before us today, and that is to sort of stop siloing the budgets that we give these folks, and instead of having the distinct sections of the budget, unifying it, it would not be the total budget would remain the same, but that way the people that care for these folks can help them make better use of that money that the Commonwealth has already decided should go to these folks. And instead of having the different silos, we would combine it. And that is the bill in short. There's some folks here from the ARC that have been involved with the work group and also with the effort from the beginning.
Okay, first, let's see if the subcommittee has any questions of Senator Suderline. All right, well, then let's hear those here in support of Senate Bill 231.
Hello. Hi, I'm Tanya Milling, Executive Director at the ARC of Virginia. Yes, we want to thank Senator Suderline for putting this in. As he said, this work group and many families with the ARC were involved in the work group to see how we could make sure people had access to assistive technology. Right now, you can't buy a lot with the cap of $5,000. This was actually a recommendation as well a couple of years ago from the Virginia Board for People with Disabilities to take and combine those caps to have greater buying power. You can certainly buy a lot more with the 15. It also allows the person and their family and their support team to do long-range planning. Think about what we might need for this year that we can utilize some better buying power and plan for what we may need in the future. The work group had other recommendations, and this is a start to open some access now without increasing the overall budget that is attached to each person.
Okay. Thank you.
Thank you.
Anybody else to speak in favor of 231? Yes, ma'am. Come ahead.
I'm Terry Morgan, the Executive Director of the Virginia Board for People with Disabilities. Very happy to be here today. The Virginia Board supports this bill. Combining the caps can allow for greater impact for people with disabilities with access to technology, access to environmental home modifications, access to electronic home-based supports. As Tanya said, a $5,000 cap is a really limited amount, and because of that limited amount, it really impacts the benefit of this service for people with disabilities. And if you allow that $5,000 cap across each of the three services to be combined to a $15,000 cap, it provides more flexibility, more individualized assessment of what people's needs are, and how to use those resources in a more individualized way, allowing for greater independence, health, and safety.
Okay. Senator Suderline.
Mr. Chair?
I'm sorry. Yeah, Senator Barker.
Yeah. Just a quick question. Am I understanding correctly that right now there is a $5,000 cap for whatever assistive technology would be used? And that under this bill, there would be $5,000 caps for each of three categories?
No. There's currently a $5,000 cap for the three services. So assistive technology has a $5,000 cap, environmental home modifications has a $5,000 cap, and electronic home-based supports has a $5,000 cap, a total of $15,000. So what this would do would allow those $5,000 caps to be pooled for $15,000 across those same three services. So if somebody needs a ramp for their home, a widened hallway for their bathroom so they can stay in their home, and it costs $8,000, they have access to that under this $15,000 pool cap. Exactly.
Okay.
Mr. Chair?
Yes, sir. Senator Barker.
I'm still not clear on this. If you have $0 needs in two of the three categories, and you have an $8,000 cap, $8,000 expenditure in the third category, do you get $8,000, or do you get only the $5,000 that is for that one category?
No, this would.
Before, you would only have the 5. Under this bill, you'd be able to utilize the 8 because you'd be able to take it, it's just one. So instead of having 3 sections of a budget, we're just having one section of the budget, and the total budget remains the exact same. And it'll be up to the folks that care for these folks to make the decision on how they'd like to utilize it, rather than saying, well, you can't use more than 5,000 on this section or 5,000 on that. And I say the assistive technology, and that was a good point that you brought up, that it could be for the other parts. It's just that's what so many of the folks that,
For the demand.
yeah, that's what the folks I hear from, and that's where we saw the great opportunities for progress. COVID made us, rethink some things, and we found some things that were really helpful for these folks.
Any more questions?
No, I don't think so right now.
What, Senator Suderline, what does shall take steps to mean?
Thank you.
Thank you. Are you talking about the beginning of the bill?
Yeah, first line.
It means just that we're going to start
Talking
the
about it,
process
or-
to make it happen,
Okay.
yeah.
Anybody to speak against 231?
That.
All right, Senate Bill 231 is in front of us.
Move to report.
Second.
Move- Moved and seconded that 231 be recommended to be reported. Yep,
Mr. Chair, just,
Senator Barker.
yeah, real quick. Do we have information from finance as to whether bills are requested to go there?
Finance will request them once it's on the docket for the full committee.
Okay, all right. Sorry, Senator Suderline. All right.
That's okay. I'm sure Chairman Howe will see the justice in this.
All right, call the roll.
Senator Saslaw, Senator Barker,
Aye.
Senator Donovan,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Aye.
Ayes 4, no 0.
Senate Bill 231 is recommended to be reported. All right.
Senator Hashim.
I see her, yep. Senator Hashmi, you've got several bills in front of us. Any chance you want any of them to go by, or?
Well, I have good news for you, yes.
Okay, good. What?
We love good news.
Yeah.
With SB 260, we would like to strike that bill, please.
Okay. Okay, so that's, all right. It's been moved and seconded that Senate Bill, you've made us, many of us, very happy, Senator Hashmi.
I'm
Senate
sure.
Bill 260, at the request of the patron, be stricken. And so that's been moved and seconded, and so I think we need to record a vote on that.
Senator Saslaw, Senator Barker,
Aye.
Senator Donovan,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Yes.
Ayes 4, no 0.
Okay, so the recommendation to the committee will be that at the patron's request, 260 be stricken. All right, Senator Hashmi, what else do you have?
Thank you, Mr. Chair. And SB 241.
Okay.
So both of these bills today are focused on the issues of chronic kidney disease and our critical need for supporting patients who are struggling with dialysis and struggling with the repercussions of kidney disease. So just yesterday, we also had the Living Donor Protection Act. So these are bills that are working in coordination with a focus around the impact that kidney disease is having on over 1 million Virginians. This particular bill is focused on creating a permanent renal disease advisory council. This committee would be composed of medical professionals, representatives from health centers, free clinics, and hospitals that provide dialysis, patient advocates and representatives. The committee's work is to provide recommendations for improving the kidney care system here in Virginia, and particularly focused around care coordination and prevention. There is a great need in Virginia for education of our population so that kidney disease and the issues of chronic kidney disease can be prevented. And the committee will develop programs to educate medical professionals and the public about treatment options and organ donations. So that is the first bill, and would be happy to take any questions. I don't know if that we have anybody that's been able to make it here to speak to the bill.
Okay. Well, let me find out if there are any questions from the subcommittee. Senator Donovan.
Senator Hashmi, Mr. Chairman, would you clarify what the challenges are right now for access? Renal care, dialysis, transplant are amazingly funded by Medicare. So what are the access problems now that necessitates
to having this.
Yes.
So right now we have one thing we've learned in conversations with many of our physician community is that there is not advanced education that would help our patients understand the impact of kidney disease on their lives. And there is also a great need for physician training to focus on kidney disease and related issues. The early diagnosis is absolutely essential, and a lot of times, as our physician community, the nephrologist and others who focus on kidney disease point out that when patients go to see their regular physicians on an annual basis, a lot of times those markers for kidney disease are missed, and it is at the point of crisis when they are identified. So being able to assist our physicians in understanding what they're looking for, how to counsel and treat patients early in advance before we reach the critical crisis points, that would be a major first step for us.
Mr. Chairman,
Senator Donovan.
what would be the fiscal impact? I don't, there are an enormous number of resources nationally, physicians. I'm shocked that they're suggesting that physicians aren't diagnosing because it's part of the routine evaluation. Now, there may be people that aren't going to the doctor. But I'm curious how much, I'm always hesitant about the state being the purveyor of things that are really in the medical arena. So what would the cost be of another?
So we
committee?
received the fiscal impact, and we put in a budget amendment, and I believe the fiscal impact that we just got this morning was $48,000 annually. Did you have, by any chance, get the fisc on that?
I did not receive a copy of the fiscal impact yet.
Senator Hashmi, do we do this for any other types of diseases?
We have a great deal of resources around cancer care and cancer treatment, and so my second bill is really seeking to replicate the kind of support and resources that we have for cancer patients and making sure they and their families are receiving support. But kidney disease is a crisis among many, many populations, most especially among our underserved communities, especially in our rural regions where they don't have the kind of access to education, knowledge, information to support them.
Anybody else on the panel have a question? Okay. And I think we've taken, offered up public support. Anybody else out there that wants to add in support for 241? Against 240? Oh, yes, ma'am. I'm sorry. Come forward.
Hi, my name is Jennifer Spangler. Usually I'm wearing my mental health advocate hat, but I would just like to commend Senator Hashmi for this effort. I have a very, very close friend who I watched go through dialysis. He's my age, I'm in my 40s, he's very young. He lived in the New River Valley, and it was incredibly difficult for him. And so I do hear you, Senator Donovan, I absolutely do. But I think that, especially for rural folks, this could be really helpful. So, thank you.
Anybody else? All right, bill's in front of us.
Move to report it. Or recommend.
Second.
It's been moved and seconded that we recommend reporting Senate Bill 241. Call the roll.
Senator Saslaw, Senator Barker,
Aye.
Senator Donovan,
I'm a no.
Senator Suderline,
No.
Senator Lewis.
Aye.
Ayes 3, noes 2.
All right, Senator Hashmi.
Thank you, Mr. Chair. And the second bill, 242, is in coordination really with 241, and this is to develop a patient navigator network. These navigators are the model would be built around the Virginia Cancer Patient Navigator Network. And again, it would include trained medical professionals such as nurses and social workers, people who, and perhaps even coaches, other individuals who have also gone through end-stage renal renal disease care themselves or their family with their family members. These navigators would specialize in educating patients with treatment choice education, as well as assist the patients with insurance and finances, also helping patients engage in home dialysis, which is a growing area for medical treatment. As we know, dialysis treatment takes the quality of life away from patients, as they have to spend much time and effort to receive dialysis treatment options. But if they are able to do home dialysis, which is now more readily available through technology and through the assistance of home healthcare workers, they would have the option of independent care within their home and be able to have a better quality of life. And again, dialysis treatments are increasing in Virginia, and we would hope that we are providing full service access and better quality resources for patients as they're facing these issues.
All right. Any questions from the subcommittee for Senator Hashmi?
I have one, Mr. Chairman.
Senator Donovan.
Fiscal impact.
Thank you, Senator Donovan and Mr. Chair. This the fiscal impact, I believe, was again around $40,000, but we can confirm that. But I believe that was the report that we had received this morning.
Mr. Chairman, speak to the bill.
Senator Donovan, go ahead.
Yep. I will say again, I work with the transplant program at Henrico Doctors Hospital. This is an incredibly sophisticated program, and so is dialysis. They have nurse navigators that are engaged. Again, it is one of the highest reimbursement rate services that Medicare pays for, down to transplant and all the medications after transplant. I would say that many of the nurse navigator programs around the country for other disease states are modeled on the programs. We shouldn't be duplicating them in the state. They should be at the provider center where they're getting their care. And $40,000 a year doesn't even pay for one nurse navigator. So it's not possible that we would be able to improve on the services that are already embedded in the Medicare reimbursement that is done federally.
All right. Does that spawn any questions? Or Senator Hashmi, you want to respond? Go ahead.
Yes, thank you, Mr. Chair. Again, I think we have wonderful resources here in the Richmond area, as well as in Northern Virginia and elsewhere. And really, what we need to expand is opportunities for similar kind of support programs in our rural communities, where we see the crisis really of chronic kidney disease. We see individuals who don't receive the treatment or have the options, and many end up receiving amputations of limbs as a result, because they haven't been able to get the kind of support and care that they need earlier in their disease progression.
Mr. Chairman, follow up.
Senator Donovan.
If they're in a program, if they're diagnosed with this diagnosis, they have a nurse navigator, even in the rural areas. And the $40,000 would be so much better spent on Medicaid covering home services of some sort, rather than having an infrastructure that is not in any way going to be parallel to what is already provided and paid for by the federal government with Medicare.
Any other questions from the subcommittee? Does anybody in the audience want to speak in favor of Senate Bill 243? Anybody want to speak against 243? 243 is in front of us.
It's 240, yeah, 243. Thank
Move
you.
the recommended be reported.
No second. Okay, fails to move forward, or I guess the recommendation would be.
The recommendation will be reported to the full committee,
Right.
and then the full committee can do whatever it wants.
Yeah, right, okay. What George said. Okay. All right, Senator Hashmi, is that all you have?
That is all I have. Thank you, Mr. Chair.
Senator Donovan, you're batting cleanup for us. There was no second.
Oh, no motion, okay.
Yeah.
Mr. Chairman, I have before the committee Senate Bill 426, and I have a line amendment for which I search. The line amendment would be on line 197, which is in the body of the language relevant to the change in the bill. Under BII, it says patient-initiated asynchronous consultations. And, oh, good, thank you. And the amendment would insert after consultations in the context of an existing provider-patient relationship. And what this bill seeks to do is really to use some of the technology that we've been expanding upon here in the Commonwealth over the last few years to help with remote monitoring. We have very sophisticated means of looking at metrics, including blood pressure, even prenatal kinds of things that would help prevent readmission or return to ER for patients with chronic disease. It would be an excellent investment for the Commonwealth. And the only change I wanted to make is that we have very strict code guidelines about bona fide patient-physician relationship and asynchronous and telemedicine. And asynchronous consultations are not an acceptable form of initiating a telemedicine relationship, but they are a means of actually following up with a patient you already have examined and know. So provider-to-provider consultations, asynchronous when you already have a relationship, and then for acute care conditions for which remote monitoring might actually reduce readmission or ER visits. And that, Mr. Chairman, is the bill.
All right. Oh, that's right. Let's get the amendment in front of us.
Thank you.
Moved, and Senator Barker seconds the amendment.